can start the free paper now. Requesting all the presenters to be stick in time. So first paper, presenting author is Dr. Dhania BC. Inside.
Good morning. Myself Dr. Dhanya. I am presenting the topic bitemporal hemianopia, diverging the cypresses. Bitemporal hemianopia is a classical visual field defect associated with the chiasmal involvement. As you all know that the nasal fibers of the retina decussate at the chiasma and form and join with the temporal fibers at the chiasma, and that will result in any damage to that area that will result in bitemporal hemianopia. So these are the common etiology involved the chiasma: compression, inflammation, demyelination, infiltration, and ischemia. Among these, compression is the most common cause, and in that we are commonly see diseases like pituitary adenoma and craniopharyngioma. We have carried out a retrospective study where we found out other causes of bitemporal hemianopia, which include glioma, meningioma, epidermoid cyst, trauma, acute zonal occult outer retinopathy, TB, arachnoiditis, ethambutol toxicity. So first three that comes under compressive lesions. Coming to the first case, a 19-year-old girl presented with the defective vision right eye for 2 years, left eye for 3 months, associated with headache. Vision is 6/6 and both eye fundus shows temporal parallel of the optic disc. An HFA shows bitemporal hemianopia and MRI suggestive of optic pathway glioma. Patient underwent right three-diagonal craniotomy and decompression of the tumor. After 2 weeks of post-op, vision was 6/6 with no resolution of the field defect. Another girl, 16-year-old, presented with a sudden onset defective vision right eye. Right eye vision 1/60 and left eye 6/6. With fundus shows right pale disc and left eye shows temporal parallel of the optic disc. MRI suggestive of epidermoid cyst, and that patient underwent right diagonal craniotomy with gross excision of the lesion. In post-op vision improved in right eye. 52-year female patient presented with a defective vision right eye. Vision right eye 6/12, left eye both eyes 6/12. Fundus shows temporal parallel of the optic disc. An MRI suggestive of meningioma involving the planum sphenoidal and diaphragma cellae, compressing the optic chiasma. Unfortunately, we lost the follow-up. Under male with prior history of trauma presented with a defective vision right eye. Right eye shows pupil involving complete Turner palsy, and the fundus shows both eye temporal parallel. And MRI is inconclusive, and we treated conservatively. Next case is a 43-year-old male presented with defective vision on the temporal side. Both eye vision is 6/6 with the right eye fundus shows right eye anterior vitreous facial with the peripapillary and peripheral RP changes, and left eye shows peripheral RP changes. And it was diagnosed as acute zonal occult outer retinopathy, and it was treated with the steroids. The next two patients presented with tuberculosis on ATT and with defective vision both eye. Fundus shows both eye temporal parallel and field shows bitemporal hemianopia. And we proceeded with the MRI, and the first case it shows features suggestive of TB arachnoiditis, and it was treated with the ATT. And next case, the MRI was normal. The VEP shows with decreased amplitude, and it was diagnosed as ethambutol toxicity. And we discontinued the ATT, and the field improves. So, on concluding, there are rare presentation of bitemporal hemianopia other than pituitary adenoma and craniopharyngioma, and it is very important to investigate patients with a temporal parallel with good vision. Thank you.
A very interesting and a very good presentation. Only thing is you could have added that what the incidence of each diseases. For example, you mentioned tuberculosis. So the incidence in our country, that you could have added.
Okay.
Because it's so common
to
have tuberculosis
so
and pituitary adenoma, isn't it?
Yes.
Good presentation.
Thank you, madam.
any other toxic amblyopias, any other toxic nutritional toxic, those etiologies did you just come across with this?
No,
You
bitemporal
studied with these
hemianopia, no
diseases?
madam. Other central
Just
scrotum
temporal.
is there, but bitemporal hemianopia we usually dealing with the ethambutol only. We are doing one study on that ethambutol.
Okay, thank you.
Thank you.
Thank you.
Good.
Thank you, Dr. Dhania. Now I welcome Dr. Siddharam.
Good morning. My topic of presentation is ocular manifestations and visual field changes in intracranial tumors. It is a prospective observational study. Ocular manifestation occurs more frequently in intracranial space occupied lesions. Ophthalmic signs and symptoms form a major part of presentation. It is most of the time it is due to raised intraocular pressure. Presenting complaints most of the time is diplopia and defective vision. Other ocular signs such as papilledema, abducent nerve, facial nerve palsies. Most of the time here for ophthalmic presentation, headache and defective vision. And ophthalmologist plays important role in diagnosis and referring of the patients. CT and MRI approach help in early diagnosis and planned management. The purpose of this investigation to assess the types and site of intracranial tumor that cause neuro-ophthalmic manifestation, visual field test to assess the type of field defects and correlate with the tumor. Aim of the test study the various ocular manifestation patients with intracranial space occupying lesions and visual field defects caused by intracranial space occupying tumors. It is done in EMS BB Nagar around 2 years, and you are included patient with radiologically proven intracranial tumors and give consent for study, and excluded for uncooperative patients with deteriorating general conditions or marked behavioral changes. Methodology: in each patient's clinical evaluation done after detailed history, complete examination of CNS included higher functions, cranial nerves, motor system, sensor system, cerebellar system is done. For ophthalmic examination, we examined the Snellen chart, color vision with Ishara chart, pupillary reactions, extraocular movements, and corneal reflex, and slit lamp examinations for all patients. And these patients, we are recorded the visual fields by Humphrey perimeters. Totally, we included 78 patients. Most of the time, 30 to 40 years of the age, most common tumor was pituitary adenoma, followed by meningiomas, and in first decade, glioma and craniopharyngiomas. We are included, females is 46 patients and males is 32 patients. Here, most of the time, these patients comes with ophthalmic department, around 52%, followed by the neurology and medicine. Presenting complaints is headache, defective vision, and diplopia in 9% of the patients. These patients, visual acuity, around 6/16, 20% patients, and 6/12 to 6/60, 34% of the patients, and 6/6 in 36%, and less than 6/16, 16% of the patients. On examination, there is 2 patients presents with ptosis, proptosis in 3 patients. On entry segment examination, there is internuclear ophthalmology in 2 patients and nystagmus in 6 patients. There is 27% of the patients with 6 nerve palsy and 20% in facial nerve palsy. Pupillary defect on that swinging flash test, that shows 28% of the people shows RAPD. Fundus examination, 38% presents with papilledema and 20% with optic atrophy. Most of the time, posterior fossa tumors present with papilledema earlier than pituitary tumors. In our study, there is pituitary adenoma, comes around 25 patients, meningioma 20, craniopharyngioma L1, glioma 8, CP angle tumors 6 patients. Here CP angle tumors around 20%, perichiasmal tumors 24%. Visual defects, most common is bitemporal myopia around 20%, enlargement of blind spot 6%, peripheral constriction in 6% of the patients. Patients mostly in the age group of 30 to 40 years were affected regularly. This according to other studies done by Rao et al., which showed 52% incidence 3rd to 4th decade. 42% present with headache, it was the most common symptom, and papilledema was usual common presentation with 6 nerve palsy. Out of 78%, 25% had pituitary adenoma. Visual field is seen in most of the patients, out of which bitemporal image frequently documented. Totman et al. Noted visual fields affect more frequently than visual fields. Perichiasmal tumors were found to be the most common regular tumor. Conclusion, ophthalmic signs symptoms form a major part of presentation in patients with intracranial tumors, and these impulsions should not be missed as we are missing out a big diagnosis. Health education, complete ophthalmic evaluation essentially prevent tumor, it may lead to permanent blindness. These are my references. Thank you.
Any question?
Good presentation. How do you differentiate the headaches, the regular headaches from this kind of a headache?
Usually this is continuous. Along with that symptoms will be vomiting and some other symptoms we have to associations we have to consider, and we have to examine these patients. If any other association, you have to investigate for MRI or neurologist opinion.
I'm just asking about just headaches. Like, like for example, we say that ENT problems, the headache is more in the morning. Eye problems, the headache is more in the evening. So this headache, is it a throbbing headache or it's
throbbing
a
type of headache? Throbbing type of headache and slightly continuous, madam. That will be like duration around a month. It will be like throbbing type and slightly continuous.
Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Our next presenter, Dr. Vimisha Amen. Please.
Good morning all. I am Dr. Vimisha. I will be talking about Good morning all. I am Dr. Vimisha. I will be talking about intracranial space occupying lesion in neuro-ophthalmology. %60% of patients with intracranial space occupying lesion present with ophthalmic manifestation, and they constitute one most common reason for neuro-ophthalmology consultation worldwide. Objective of our study is to evaluate myriads of symptoms in neuro-ophthalmology in a patient with intracranial space occupying lesion. Also to highlight the role of ophthalmologists in early diagnosis and prompt management of brain lesion with a multidisciplinary approach. In all patients, detailed history, refraction, slit-lamp examination, neuro-ophthalmology evaluation and fundus examination done, and neuroimaging done for all. Our study is a retrospective descriptive study which conducted in a tertiary healthcare center in South India. Over a period of 1 year, around 30 patients were recruited, and all patients above 16 years of age with a lesion confirmed by neuroimaging are included in the study, and patients with pituitary macroadenoma and cerebral metastasis were excluded. On coming to result, out of 30 patients, 20 were female, and mean age of our study population was 47.5. On analyzing the result, most common presenting complaint was diminution of vision, followed by headache, field defect and diplopia. And headache was the most common neurologic symptom presented in 23% of individuals. Coming to discussion, after analyzing histopathology and neuroimaging, we found that most common primary lesion in our study population was meningioma, which found in around 40% of individuals, followed by schwannoma in 30%, glioma in 13% of individuals. Analyzing symptomatology, meningioma patient mainly presented with the optic nerve head pallor, papilledema and field defect, and schwannoma patient presented with the papilledema, diplopia, 7th, 5th and 8th cranial nerve palsies, and glioma patient mainly presented with a headache, multiple cranial nerve palsies. It's a coronal T2 weighted image of one of our patients having parieto-temporal heterogeneous mass suggestive of transitional meningioma, and the patient with the axial flare image showing homogeneous mass in supracellular region suggestive of tuberculous cellular meningioma, fundus image of another patient with optic nerve head pallor who had cellular tumor. It's our case of trigeminal schwannoma with a Meckel's cave extension. In conclusion, nearly 2/3 of our study population had poorly neuro-ophthalmologic manifestation as major complaint, which implies eyes are indeed windows to brain, and cross relationship of other disciplines such as radiodiagnosis, neurosurgery and pathology can go long way in our clinical practice. Limitation included in our studies were absence of radiology, neurosurgery facilities in our center, and those patients with the financial constraints were having trouble going through expensive imaging modalities and regular follow-up. Those are my references. Thank you.
Good. Good presentation. Thank you very much. Eye is a window of the brain and eye is also tail of the brain, isn't it? Yeah. Eye is the only organ where, you can see live vessels and things like that. Any periventricular leukomalacia or cerebral palsy or these kind of children were not included in this study? Did you include them? No.
No.
Yeah. Okay.
How was the fundus findings? Like both, there was papillae both is. Any unilateral disc edemas did you made out in these cases? Any one disc was involved? Unilateral disc edemas? No.
Thank you.
I think we should wait for them
Yes.
to start the study. Dr. Mandal.
So next presenter is Dr. Mili Mandal.
A very good morning. This is Dr. Milli Mandal, and my topic of presentation today is unveiling the mystery, diabetes, drooping eyelids, and missing brain arteries. So according to World Health Organization, the total number of diabetics have increased to 422 million. There have been a 3% increase in diabetes mortality and about 2 million deaths due to diabetes and its complications. So if I were to talk about the complications of diabetes, diabetic neuropathy is one of the most common complications, and among them, oculomotor palsy is one of the most frequent neuro-ophthalmic manifestations. So what is the etiology behind the oculomotor palsy? It is hyperglycemia-induced damage to the nerve cells, resulting in neural and ischemic change. So here I present you a case of a 61-year-old female who presented to us with acute onset right upper eyelid ptosis for 7 days, which was non-progressive without any diurnal variation. There was a positive history of headache and 2 recent episodes of syncope.
Dr. Milli, can you just hold on for a minute because there's no display here?
Okay, sure.
We'll give you extra time, don't worry.
Okay, ma'am.
This display is not functioning.
Okay, ma'am.
Just call the audiovisual guy. I think the frequency is increasing. Yeah, can you? Yeah, please go ahead.
Shall I start now?
Yeah,
Okay.
please.
Okay. So there was a positive history of headache and 2 recent episodes of syncope. There was no associated history of muscle weakness. Coming to the past medical history, she was diabetic and hypertensive. General examinations and systemic examinations were within normal limit. Coming to ocular examination, her right eye visual acuity was finger count 4 meter and left eye was
Excuse
finger
Dr.
count 3
Mili,
meter.
please.
There is some serious problem, I think, in this
Audiovisual.
screen on this side. Can you please rectify it once forever? Or should we turn on that side? Excuse me. Yeah, that's better, I think, because the. Can we shift the table on that side? Millie, we are sorry for the interruption.
No, ma'am.
You can, take a deep breath. Excuse me. either you sort it out once for all, or we move the table on that side. Whatever you say, because the moment you go out, the light is going out. Yeah. Give me your number. This is a number. I think I might be having your number. Give me a missed call. Can you please wait for some time? Excuse me. Can you please wait for some time? Or we shift the table on that side, because it will again go, and Miri will be very upset with us. Please carry on.
Ocular examination revealed a distant visual acuity of finger count 4 meter in the right eye and 3 meter in the left eye, not improving with pinhole. The right eye showed severe ptosis with corneal sensations intact in both the eyes. MRD1 in the right eye was minus 4 mm. Pupil were reacting to light in both the eyes.
Yep.
Next slide.
Next.
Extraocular movements were restricted in all gazes except in lateral gaze, and full and free in all gazes in the left eye. There was a mild exodeviation of 15 degree. Fundus findings were within normal limit. The lens was cataractous in both the eyes. Coming to investigations, revealed PPBS of 256 milligram per DL and HbA1c of 8.3%. So this was a case of uncontrolled diabetes. We also went on with MRI brain, which in turn showed ischemic demyelination in the bilateral basal ganglion and involvement of periventricular white matter and cerebral edema. Then with the MRI brain, we found a very interesting finding. It was the case of missing arteries in both the cerebral hemisphere, bilateral posterior communicating artery agenesis. So concluding this, so this is a case where there is bilateral posterior communicating artery agenesis, which in turn is compromising the posterior circulation. That in turn is predisposing this female for recurrent episodes of acute ischemic strokes. Also, this female is suffering from type 2 diabetes mellitus, which itself is a contributing factor for ischemic nerve damage. So what do we conclude? The oculomotor neuropathy in turn here is resulting due to pupicoma agenesis and type 2 diabetes mellitus coexisting together. But how does it differ? Here in this case, we have to treat the patient with initial dose of steroids and then followed by conservative ways of the way we manage diabetic neuropathy patients, which includes strict glycemic control, lifestyle changes, and educating the patient regarding the same. This is the 3-month follow-up picture of the patient. Patient was on regular insulin, Glargine, OHAs, and aspirin and atorvastatin. Thank you.
Thank you. Any
Thank
question,
you very
madam?
much. Yeah. Is there any correlation between the duration of diabetes and the onset of this, artery issues that you were talking about? Is there any correlation?
Correlation between
the duration of diabetes?
Yes, ma'am. Yes, ma'am. Yeah. There is a correlation. It is more in. It's most commonly seen in type 1 diabetes, and with the duration, as the chances of retinopathy also increases, neuropathy also increases.
Thank you.
There was no TIAs or there was no vascular events before this. Patient did not have any.
Yes, ma'am.
history.
I mentioned in the slide. There was an episode, 2 episodes of syncope, an episode of headache.
Okay. So thank you.
Okay, thank you, sir.
Next, I call Dr. Durga Priyadarshini.
A very good morning to one and all. So my paper for today is Neuro-ophthalmic manifestation of acute demyelinating encephalomyelitis in Indian pediatric population. ADEM is characterized by encephalopathy with multifocal CNS demyelination, and its diagnosis is based on clinico-radiological correlation and exclusion of conditions that mimic ADEM. So objective of the study was to analyze children diagnosed with ADEM presenting with neuro-ophthalmic manifestations. We looked into the data between June 2018 and May 2023, and we included children less than 17 years of age who had presented with the neuro-ophthalmic symptoms with acute or previous history of ADEM and who did not fulfill the diagnostic criteria of MS and who had come for at least one follow-up visit post-treatment. It was a retrospective analysis, and the sample size was 14 patients, and the following data were collected. I'm sorry, I think you have taken the wrong presentation. The PPT, can you see the... Okay, let's move on, yeah. So,
Again, there is problem.
sorry ma'am, I think the wrong PPT was uploaded.
May I
Can
request audiovisual people please come on.
Ma'am, can I
Yeah,
re-upload the
you can,
PPT?
you can take your time. You can just go and
Next
check your
presentation
presentation.
can-
Yeah, you can do the
I'm
next
sorry
after,
about it, I think
you
the
know.
wrong PPTs have
Yeah, I
been
think the
uploaded.
next person,
Thank you.
can do the presentation. Yeah.
I think again there is problem here.
Nayanika Bose. Yeah, I think we move the table
think
on
better
that side
we should go this
rather than telling them repeatedly. Audio visual. Shift the table on that side.
Neuroophthalmic manifestations of ADEM in Indian pediatric population. It's characterized by encephalopathy with a multifocal CNS demyelination, and its diagnosis is based on clinico-radiological correlation and exclusion of conditions that mimic ADEM. So the objective of the study is to analyze children diagnosed with ADEM presenting with neuroophthalmic manifestations in Indian population. So we looked into the data between June 2018 and May 2023. We included children less than 17 years of age who had presented to a neuroophthalmic clinic with acute or previous history of ADEM and who did not fulfill the diagnostic criteria of MS and who had come for at least one follow-up visit post-treatment. So the sample size was 14 patients and it was a retrospective analysis. The following data was collected. All patients had received IV followed by oral steroids. There was a female preponderance, 64% were female. The mean age of presentation was 8 years. Mean follow-up duration was 37 months. 57%, that is 8 out of the 14 patients had presented first to the ophthalmologist, and the remaining 6 out of the 14 had presented to neurologists, and then they were referred to ophthalmologists for opinion. Looking into the results, the clinical characteristics, 8 of the 14 patients had viral prodrome. Mean interval between ADEM and the visual symptom was 30 days. And the most common neuroophthalmic manifestation was optic neuritis. And the most common ADEM symptom that our group had was headache. The mean vision on presentation was logMAR 1.1, which was profound loss. But in the last follow-up, the visual acuity, they had improved. The logMAR mean vision on last follow-up was logMAR 0.4. And the p-value was significant. MRI brain and orbit was done in all patients, and all patients had ADEM-like lesions. And MRI orbit showed T2 signal in 12 out of the 14 patients, and 2 patients had contrast enhancement. MRI spine was done in 4 patients, and 3 of them had T2 hyperintense signal. And this is a classical MRI seen in ADEM patients and optic neuritis in one of our patients. And looking into the serum markers, 9 out of the 14 patients had NMO and had undergone NMO and MOG antibody, and 4 out of the 14 patients had only NMO antibody, and 1 patient did not undergo both NMO and MOG antibody. The prevalence of these seromarkers in our group, we noted that 5 of them were MOG positive, none of them were NMO positive, and 4 were negative for both NMO and MOG, and 4 patients were negative for NMO, but their MOG status was not known. And in this group, whose MOG status was not known, they were all classical ADEM followed by optic neuritis, and their visual prognosis was good. But the other group, the seronegative, who were negative for NMO and MOG, 1 patient was classical ADEM, but the other 3 patients had varied presentation. I have tabulated the 3 patients. 1 patient had presented with paraplegia secondary to myelitis, and we noted that all 3 of them had very poor visual prognosis in the last follow-up. Looking at the relapse, 6 patients out of these 14 patients had relapse, that is 42%, and the most commonly it was optic neuritis, and 1 patient had recurrent ADEM. The average relapse interval was 3.75 years, and 2 patients had relapsed within 2 months, and obviously they relapsed when their oral steroids were tapered. 3 out of these 6 patients had MOG positive, and the 4 out of these 6 patients who had relapsed had residual ophthalmic symptoms, either in the form of visual impairment, persistent field loss, and pupil abnormality. And patients who had relapsed were all treated, had the treatment escalation and put on maintenance therapy. Going to the discussion, ADEM is a rare polysymptomatic demyelinating event which can present as vision loss secondary to optic neuritis and encephalopathy, which can manifest as headache, behavioral change, irritability, and lethargy too. There's a slight male preponderance in ADEM according to the literature, but our cohort had a female preponderance. Probable reason could be the association of pediatric optic neuritis with females. And the most common neuroophthalmic manifestation in ADEM is optic neuritis, which is very similar to the data published. And there is also something called as ADEM-ON. In current studies, they have noted that as a distinct clinical entity. 3 of our patients had cranial nerve palsy due to midbrain involvement. The association between MOG antibody and ADEM is very strong. In our paper, in our group, it was 35%. The subset of patients who were MOG negative, we were not able to they were not classifiable under any defined disease entity, but the sample size is too small to comment on its significance. And the visual outcome in our group was very good. The prolonged inter-attack interval, especially in the MOG positive patients, indicated that they need long-term use of steroids or immunosuppressants, and none of our patients had relapsed when they were on maintenance treatment, but of course they need further studies to confirm these findings. So the limitation of our study is same as in any study which is retrospective. And I would like to conclude saying that ADEM can present first to any ophthalmologist, so one should be aware about this entity. Optic neuritis is a common manifestation of ADEM, and 1/3 can be MOG positive. Being a small cohort with a poor follow-up, it's difficult to conclude on the prevalence of pediatric MS, and this merits further studies on ADEM in Indian population. Thank you.
Very nice presentation. Thank you. So we can call our next presenter.
Thank you.
Dr. Noenika Bose. Dr. Noenika Bose.
Good morning, everyone. I'm Dr. Noenika Bose, and I will be presenting my paper today on the predictive value of retinal nerve fiber layer thickness for postoperative visual improvement in patients with pituitary macroadenoma. As we all know, pituitary macroadenomas are of importance as they compress the chiasma and cause visual defects. Reliable and consistent predictions of visual outcome for surgical decompression of pituitary macroadenomas are difficult. Although RNFL thickness has been studied before, no defined cutoff has been defined, and the lack of a well-defined cutoff for RNFL makes it difficult to counsel patients regarding visual outcomes. Our study attempts to evaluate the predictive value of RNFL thickness for improvement in visual fields and visual acuity in postoperative patients of pituitary macroadenoma. The study adds a reasonable objective cutoff for preoperative RNFL thickness that can predict postoperative improvement in visual field. It can also help in research and daily practice by preoperative counseling of patients to be done objectively. It was a prospective observational study conducted at a tertiary care hospital of Eastern India. Patients were selected for 3 months from January to March and followed up for a duration of 1 year. Preoperative and postoperative visual examinations were done, and ROC curves were constructed for RNFL values to define the ideal cutoff value of predicted improvement. The cases selected underwent MRI and were planned for endonasal endoscopic excision. A complete ophthalmological evaluation was done. Patients with papilledema, glaucoma, high myopia, extensive retinal pathology, and on treatment with cabergoline or prior pituitary surgery, radiation therapy were excluded. Those who underwent greater than 90% tumor resection were selected for the study. Preoperative tumor volume was calculated from contrast-enhanced MRI of the brain using the Cavalieri's principle. Ophthalmological assessment was done for visual acuity by Snell's chart under optimal lighting conditions and recorded in logMAR units. Visual field was analyzed in the HFA 32- program CETA standard, and visual field effect was assessed from mean deviation in decibels and visual field index in percentage. OCT RNFL was done preoperatively. The postoperative visual outcome was done in the 2 to 4 months follow-up period after the surgery. Improvement in visual acuity was defined as any improvement from the baseline. Visual field was documented as improved if there was improvement in mean deviation by 5 decibels or visual field index improvement by at least 10%. Analysis was performed. The table 1 shows the demographic and clinical profile of the patient. 29 patients were selected with mean age of 43.9 years and most were male. The preoperative visual function showed that the major complaint was a decrease in vision in 72.4% patients, and the most common field defect on HFA was temporal hemianopia. All eyes with total disc pallor and had a reduction in visual acuity, and all eyes with any disc pallor, temporal total, had some form of visual field defect. Table 2 shows that in our patients, the mean preoperative RNFL thickness was 89.02 micrometer, and the RNFL in different quadrants was significantly thinner in eyes with visual dysfunction and disc pallor. The mean follow-up period was 10 months, and Table 3 shows a significant postoperative change in visual acuity, mean deviation, and visual field index. The rate of postoperative improvement for visual acuity was 75%, that of visual field defect was 61.9%. Table 4 shows a univariate analysis of the prognostic variables with respect to 32 eyes with visual acuity defect and 42 eyes with visual field defect. It is seen that with respect to visual field defect, eyes that improved had significantly better preoperative visual acuity, thicker RNFL, and smaller tumor volumes. The Table 5 shows a logistic regression analysis of prognostic variables, which shows that RNFL thickness remains significantly associated with improvement in visual field defect. The average RNFL thickness of 81 micrometer predicted an improvement in visual field defect with 73.1% sensitivity and 62.5% specificity. Predicting visual outcome following surgery for pituitary microadenomas are difficult. Deterioration of vision can occur during intraoperative, postoperative complications, which are unpredictable. Montre et al. Conducted a study using the macular thickness with macular RNFL and ganglion cell layer to correlate with visual field loss. In our study, we used the peripapillary RNFL thickness. Compared to Danish Mayer et al. Study, the eye shows improvement in visual acuity in our study, 75%, and there was no significant difference in RNFL thickness between those who had improvement in acuity and those who did not. Our study demonstrated an odds ratio of about 1.1 for improvement in visual field effect for 1 micrometer of mean RNFL thickness. Principal strength of the study was that it was prospective. Limitations of the study was that follow-up period was variable. Postoperative visual fields may have been better in literate patients. The sample size was not too large, and we did not study the ganglion cell layer complex. So it can be concluded that preoperative average RNFL thickness of greater than 81 micrometers can be used as an objective predictor. These are my references. Thank you.
Thank you, Dr. Noyanika. So next I call upon Dr. Aditi Mishra. Dr. Aditi Mishra.
Good afternoon, everyone. Today, I, Dr. Aditi Mishra, presenting a paper on ocular ultrasonography and SDOCT to distinguish between grade 1 and grade 2 papilledema and pseudopapilledema, co-author Dr. Professor Eva Tirki. Introduction, the differentiation between the two is a challenging task, yet critical decision needs to be made. Often, patients with true papilledema are being confused with pseudopapilledema. The modalities such as B-scan and OCT can be a cost-effective invasive outpatient procedure that helps in the diagnosis and the management of the patients with optic disc edema and papilledema. Now, aim is to evaluate the role of ultrasonography, especially in grade 1 and grade 2 papilledema. Also, analyze the optic nerve head and peripapillary retina using SDOCT. Materials and methods. Study design was a cross-sectional observational study. Study center was SSMC Riva. Duration was September 22 to March 24, and a sample size of 60 patients was taken. Inclusion criteria, the patients with have a grade 1, grade 2 papilledema, and the other group was pseudopapilledema. The exclusion was the children below the 18 years of age and patients with hypertensive retinopathy, diabetic, or traumatic optic neuropathy, and the patients which have the grading greater than grade 2. Now, the patient underwent comprehensive general examination and comprehensive ophthalmic examination was done. In ocular ultrasonography, the following parameters were taken into consideration, such as optic nerve sheath width of greater than 3.3 mm, 30-degree test, which is the decrease in the optic nerve sheath width by 10% on abduction. On B-scan mode, the elevation of the optic disc, and we also look for the crescent sign. For spectral domain of OCT parameters, we have taken into consideration PARNFL, brush membrane opening, optic nerve head volume, and GCIPL thickness. In the total, 60 participants were taken. 30 were papilledema, which included grade 1 and grade 2. The other 30 was the group of pseudopapilledema. This is the chart, bar chart showing the optic nerve sheath diameter, which was increased in 20% of 20 patients. Total 30 patients were taken. In the other, the optic nerve sheath, the 30-degree test was found positive in 73% of papilledema. However, the same was found only 30%, 37% positive in patients of pseudopapilledema. The other in OCT in papilledema and pseudopapilledema, we have generally taken the PRNFL and GCIPL. PRNFL was increased in patients of papilledema. However, GCIPL thickness was decreased in the patients of papilledema. Brush membrane was comparable in both groups. In a study, orbital ultrasonography is found to be a sensitive tool in diagnosis of low grade, which is comparable to S.B. Carter et al., which has a sensitivity of 90% and relatively higher than 60% in Cole et al. However, in our study, along with the optic nerve sheet diameter and 30-degree test, we have also taken into consideration the crescent and donut sign. The median RNFL thickness was greater in papilledema as compared to pseudopapilledema. The Bessie et al. In this study found increase on RNFL thickness in all quadrant. Conclusion: ocular ultrasonography and spectral domain OCT both can be used to distinguish between papilledema and pseudopapilledema. 30-degree test was found positive in greater degrees of papilledema than pseudopapilledema, and SGOCT parameters RNFL was raised, however GCIPL was decreased. Both can be useful in guiding the management and the diagnosis in the patients whom the diagnosis is uncertain. These are my references. Thank you.
Thank you, Dr. Aditi.
Clinically, there is such a gross difference between, I'm just talking about the clinical presentation.
Yes,
there is a vast difference between pseudopapilledema and papilledema, isn't it, clinically?
Yes, ma'am. Clinically,
Yeah.
difference is present, but this case we are taking early papilledema and pseudopapilledema.
Even early papilledema, the symptoms are huge.
Ma'am, early studies have been done taking into consideration B scan and SDOCT parameters also.
No, the clinical examination I'm talking about.
Ma'am,
Clinical
Friesen
examination of early papilledema.
Ji ma'am. Fundus examination, Friesen grading can be done.
Not just the fundus examination, other examination. Of,
Yes, ma'am. Perimetry and color.
Early papilledema. Without any, I'm talking about clinical examination, not about the perimetry or about the papilledema, early disc blurring and all that. Compared to that, pseudopapilledema, there are hardly any symptoms, isn't it? Symptoms.
Yeah, ma'am. Symptoms are not there, but
So the question here is, is it necessary to investigate, do all these investigations in a child who has pseudopapilledema, because the clinical symptoms of papilledema are so huge.
ma'am, in
isn't it?
certain cases where drusen's
A
are
clinical
present.
correlation, I think, with this is extremely.
Yes, ma'am, I agree with that.
essential.
I agree with that. But in certain cases, the optic disc drusen and patient can present with headaches also. So we can help with this tool. We can differentiate between the two.
But the incidence of that is very low, isn't it?
Yes, ma'am. Thank you.
Yeah.
Thank you.
Dr.
Our
Shivi
next
Jain.
presenter is Dr. Shivi Jain.
Full screen.
Your display option.
Okay.
Good morning, everyone.
Yeah,
Okay. Good morning, everyone. So myself, Dr. Shivi Jain. I'm going to present my retrospective study on evaluation of changes due to hydroxychloroquine drug use on retinal electrical activity using multifocal ERG. So there's no financial disclosure. And so as we all know, hydroxychloroquine is a commonly prescribed anti-inflammatory medication for treating rheumatologic and dermatologic conditions. The multifocal ERG is a more recent electrophysiologic test that detects and localizes distinct areas of outer retinal damage in the macula and paramacular as well as discrete peripheral areas. So an abnormal MFERG generally reflects foveal cone or bipolar cell dysfunction along with source of vision loss. So the purpose of my study was to investigate the effect of SCQ drug on retinal electrical activity using multifocal ERG. So I've used single center based retrospective study design done in Netradhama Super Speciality Eye Hospital, Bangalore. We had two groups, HCQ group and control group. So in HCQ group, we have 108 eyes of 55 patients. And data was collected on variables concerning medical history, ocular history, visual acuity, anterior segment findings, fundus examination, and multifocal ERG from medical records. Similarly, in the control groups, we have taken 58 eyes of 29 healthy subjects, and similar variables were studied. So it was performed on TOMI EP1000 Pro using DTL electrodes and ground electrode attached to earlobe. Stimuli comprised an array of 61 hexagon as per ICEF guidelines. So these were the tests done for statistical analysis. And so as we see in result, mostly were females, and mean duration of HCQ use was 5.35 years. Indication for HCQ was mainly rheumatoid arthritis. And fundus finding, mostly they were normal, and 2 subjects have shown RPE changes in both the eyes. One has shown ERM in both eyes, one in ERM in one eye, and the other one drusen. So visual acuity has started on logMAR. Mostly they had less than 0.1 in the right eye, similarly in the left eye. And as we can see the results, so there was a statistically significant decrease in ring amplitude density in the rings 1 and 2. While the peripheral rings results were comparable with the control group, while there was increase in implicit time, but it was not statistically significant. Similar results can be was interpreted on box and whisker plot. This is a multi-line chart showing median changes in value from ring 1 to ring 5 in both HCQ and control group, and as you can see on ring 1 and ring 2, there's significant changes. Similarly, multi-line chart showing amplitude values from ring 1 to ring 5, and as you can see, ring 1 and ring 2 are showing the significant difference. So as we all know, HCQ is widely used in treatment of rheumatoid arthritis and SLE, and it initially causes photoreceptor damage and shows classical parafoveal distribution. It is tolerated well, but prolonged use is associated with the risk of macular toxicity. Conventional ophthalmic investigation do not pick up early HCQ changes, and HCQ retinopathy screening is still an area of debate. Novel technologies like standard domain OCT, FAF, and multifocal ERG detects earliest structural and functional changes. So AAO guidelines for screening HCQ toxicity, they have also recommended multifocal ERG as an objective test. And similar results as our studies, they were published in American Journal of Ophthalmology. Study was done by Adrian C. et al. And Seng et al. And Jonathan S. Lyon. And Mels RB and Mamar Arif have also noted similar results in the study. We have compared 110 eyes of 55 patients with normal visual acuity and fundus and who were on HCQ for more than 5 years with a control group, and we have found that ring 1 and ring 2, both P1 response densities were significantly lower. So I would like to conclude that MFERG is an excellent tool for early detection of HCQ toxicity in the macula. It can be used as an objective test to screen patient on long-term HCQ, which enables to detect toxicity before vision is affected. Limitation of study, cumulative dose of HCQ was not taken into consideration, and comparison with visual field and standard domain OCT would give more information. So these were my references. Thank you.
Thank you.
A very good study. I was actually about to ask about the cumulative dose and also about the OCT, so you put it in your limitations. If you have done OCT, what were the common things you observed in patients with?
So actually, mainly we have done multifocal ERG only, but in few patients we have done standard domain OCT also. So in that we have seen the changes in the photoreceptor and RPE layer basically.
Okay. So majority of your patients were RA patients, no? Rheumatoid arthritis, you said.
Rheumatoid, yes.
Any other, you can expect any other group of patients who will be on use of HCQs?
Like people who are on HCQ mainly, so they can be SLE, like some patients were...
dermatological, usually most of the times.
Yes.
Thank you.
What was the duration of dosage of hydrochloroquine for these patients?
So as I have told earlier, mean duration was 5 years in our patient. Like mostly patients were more than 5 years they were using.
How did you correlate, this hydrochloroquine toxicity along with other clinical symptoms? Like, what was the first sign or the symptom that you saw other than this investigation that you did?
That's what this investigation showed the changes before they got any symptoms. Actually,
Symptoms like
they were
color
sent for
blindness?
investigation by their rheumatologist. So
Yeah,
we did.
these patients were referred to you by the rheumatologist.
Yes.
They didn't come to you on your own. Either
Some
with-
patient came directly, and like we asked history and all. That time also we took, and mostly rheumatologists also referred.
Did you correlate the incidence of color blindness with this?
No, we have not.
Thank you.
Thank you very much.
Thank you. So next I call upon Dr. Ashish Pandey. Dr. Ashish Pandey.
Darren Jose. I think in place of Ashish Pandey, you are presenting. Yeah. She is presenting in place of Ashish Pandey.
Okay.
So we just write her name.
Okay. Madam, what is the reason for changing presenting authority?
Change the presenting authority. Now that she's yeah.
I'll be presenting on the behalf of Dr. Ashish Pandey. So my topic is ethambutol-induced optic neuropathy, a retrospective study of incidence and risk factors. So tuberculosis, which is considered as a global health concern and include 4 drugs, which is rifampicin, isoniazid, pyrazinamide, and ethambutol. So due to revised RNTCP 2016 guidelines, which consist of daily regimen of ethambutol, so the concern has raised about ethambutol-induced optic neuropathies. So ethambutol has a bacteriostatic action. So because of ethambutol-induced optic neuropathy, age is likely to be considered as a risk factor for the complication of optic neuropathy. So my study aims to assess the incidence and risk factors of ethambutol-induced optic neuropathy. So in this retrospective observational study, which was conducted in DOT Center, AIIMS Bhopal, from duration 2019 to 2023, a total of about 1,676 patients were recruited, out of which 986 had an ophthalmology encounter. So all of the patients received ethambutol treatment, and the demographic data was collected. We collected BMI history, smoking history, any age, gender, any medical history relevant to that, any ophthalmic data in patients of ethambutol-induced optic neuropathy. OCT records was also calculated. So the results were, all of the patients had bilateral painless vision loss, and the visual acuity ranged from 6/24 to hand movement close to face. And there was no correlation with gender and age was found. And 6 patients amongst 13 patients who had ethambutol-induced optic neuropathy were found to have red-green color deficiency. So after cessation of ethambutol also, only 1 patient was found to have visual acuity improvement from in 2 lines of Snellen's chart, with a mean recovery time of about 9.4 months. And all 13 patients had temporal disc pellar. The average RNFL thickness in right eye and left eye about 69.54 plus minus 3.07 micron, and 69.54 plus minus 2.67 microns. So these are the association of socio-demographic variables in which we included age, gender, BMI, treatment duration, comorbidity, addiction history, serology, ethambutol dose, number of fixed dose tablets, and type of tuberculosis, which was not found to be significant in our study. In linear regression analysis, the socio-demographic variables such as increased left temporal RNFL thickness and increased average RNFL thickness was found to be associated with the duration of ethambutol. So I would say that there was no significant difference in the age group we found, as in contrast to the previous studies, which suggest that age is correlated with the high correlation of ethambutol-induced optic neuropathy, and we also did not found any correlation with hypertension and smoking, which is considered to be a risk factor in previous studies. So according to previous meta-analysis, duration and doses of ethambutol was correlated to the risk of ethambutol-induced optic neuropathy. Our study also suggested that though this association did not persisted in unadjusted models, so it might be due to the prescribed ethambutol regimen, which was about 15 to 25 milligram per kg per day. So in conclusion, we did not find any significant difference in the age between patients with ethambutol-induced optic neuropathy and without ethambutol-induced optic neuropathy. And despite the revised RNTCP guidelines, which considered daily regimen to eliminate TP, there was no increase of incidence in previous guidelines, and these guidelines was seen in our case. And the toxicity of ethambutol is in our case was dose and duration dependent, with no dose being absolutely safe. So with this, thank you everyone.
Thank you.
Thank you. Next I call upon our last presenter, Dr. Darren Jose.
Allowed to present.
So good afternoon. I'll be presenting a paper on MOG antibody positive optic neuritis, clinical features and visual outcomes. So myelin oligodendrocyte glycoprotein is one of the several proteins produced by oligodendrocytes, which are myelin forming cells of the CNS. So MOG along with myelin basic protein, proteolipid protein are the components of oligodendrocyte surface membrane, which helps in the formation, maintenance and disintegration of myelin sheath. So the most common type of optic neuritis is labeled as typical or demyelinating optic neuritis, which is associated with multiple sclerosis or idiopathic. So the classical triad of features include visual loss, periocular pain and dyschromatopsia. So the phenotype of MOG IgG positive disorders or MOGAD is broad and includes optic neuritis, transverse myelitis and acute demyelinating encephalomyelitis, which is most commonly seen in children. And the classical features of MOG optic neuritis are recurrent optic neuritis, prominent disc edema and perineural enhancement of the optic nerve on MRI. So the aim of our study was to describe the spectrum of clinical presentation, neurological and MRI features and the final visual outcomes in MOG positive optic neuritis patients. So our study design was a retrospective observational case series study, which was conducted from 2014 to 2023, of which 16 patients were included in the study, of whom all were MOG positive, and the patient records were reviewed for demographical data, clinical parameters, and visual outcomes and follow-up, and the treatment instituted. So visual acuity was assessed using Snellen's visual acuity chart and categorized into mild, moderate, and severe according to the International Statistical Classification of Diseases. So coming to results, the study included 16 patients, of whom all were MOG positive, and 2 of whom were positive for both MOG and aquaporin IgG4. So it showed a slight female preponderance with 56% and with a mean age of 38 years and the age ranging from 27 to 60 years. So optic neuritis was the presenting symptom in all the patients, and optic neuritis was bilateral in 81% of the patients, with pain on extraocular movement in 25% of the patients. Recurrence of optic neuritis was seen in all patients with the maximum recurrence rate of 8 and a median of 2. So visual acuity at the time of presentation was 68% severe vision loss and with 25 having mild. So fundus evaluation showed disc edema, which was present in 9 of the 16 patients, of whom 5 had bilateral disc edema. Optic atrophy at time of presentation was 3 of 32 eyes, and no evidence of disc hemorrhage was noted in any of the patients. So on neurological evaluation, 8 of the 16 patients had neurological deficits, of whom 6 had transverse myelitis and 2 were having hemiparesis. So MRI were evaluated, which showed T2 hyperintensity involving indicating demyelination of the brain, spinal cord and optic nerves in 6 of the 16 patients. Of these 6, 4 patients showed bilateral optic nerve involvement and 2 had optic chiasmal involvement. So treatment was started with IV methylprednisolone 500 mg twice daily for 3 days as per the optic neuritis treatment trial, and was continued for an extra 2 days in the absence of improvement. The patients were then started on oral prednisolone with a dosage of 1 milligram per kg per day and was slowly tapered off with signs of improvement. And those with recurrent attacks were started on monoclonal antibodies for chronic immunosuppression. So visual recovery at follow-up. So 62% of the patients were with functional vision, and of these 28 had severe visual loss. So in contrast to those at the time of presentation, the patients showed functional vision gain on treatment. So this indicates that visual acuity at presentation is not a predictor of the final visual outcome, and severe visual impair persisted in these 28 patients. Fundus findings, disc edema was seen in 56% of the individuals, which was consistent with findings from the other studies, and optic disc edema being the common feature of MOG IgG positive optic neuritis. So in our patients, MRI revealed the optic nerve involvement was seen in the proximal parts of the optic nerve in isolation and with involvement of the optic chiasm, which was consistent with other studies. We also found that for those with T2 hyperintensity of the optic nerve, the nadir of vision loss was very severe. So of those 6 patients, 2 patients on follow-up were absent of perception of light, and 4 showed full recovery of vision. So the limitations of our study was, since it was done at a tertiary care referral center, milder forms of the disease might be missed or go undetected. So to conclude, optic neuritis is the most common presenting features or symptom of MOGAD, which is usually bilateral and recurrent with optic disc edema, and even after recurrent attack, most patients retain functional vision, and MRI mostly shows T2 hyperintensity of the optic nerve with maximal visual impairment. So these are my references for this.
Thank you. So we are about to conclude the session. I request all the presenters to come to the stage for a photograph. All presenters, please.
Yeah, I think they have presented and they have disappeared. Would request all the presenters to come for a picture. Come on the stage for a picture, please. Before we start the next session. Yeah.